send off and all that. Sorry.
We are
Yeah.
like, okay.
We are
Yeah.
live now.
So, good evening, everyone. I know it's late, but I think the topic itself is keeping everybody awake, and we are very glad that there are so many people who have joined this class at this late hour to listen to one of the most, I think, popular drugs and the most popular drug of Dr. Jay Mehta, that is the Dinogest. So, people are using it more often than a Dolo 650 for endometriosis, I suppose. So today's class will throw some light actually what is the role of the Dinogest in treating endometriosis, because as we all know, endometriosis is an enigmatic disease and some people feel that there is no need to do surgery and they can go forever on medical management. And this is one of the latest drugs which has been available from a couple of years, and it has gained a lot of popularity among non-operative uh, gynecologists who swear by the results, and especially fertility specialists who also think that like this can change the game of endometriosis for patients with fertility issues. Yes, over to you.
Actually, guys, this is going to be a very, very scientific masterclass, and I'm going to be trying and talking things not what we think Dinogest does. I'm going to be trying and talking things of what Dinogest actually does based on the manuscript of Dinogest submitted by the manufacturer, and of course, I'll be touching upon some guidelines as well. Okay, so first things first, Dinogest is actually not a new drug at all. It was actually founded in Germany in 1980s 1990s, and for almost a decade, 10, 15, 20 years, it was used in Germany predominantly as an oral contraceptive pill along with ethinyl estradiol and a combination of Dinogest. All right, of course, only after that, little later, the use of progesterone alone in the form of Dinogest was discovered, and it was, tried to be used in patients who are having severe endometriosis. And from there, it actually started that okay, you can also use progesterone alone for endometriosis, and the only thing the product states is that it can be used as a first line management for pain management, which is associated with lesions of endometriosis. Correct? Now, one more thing which I just want to tell people, it is currently not approved as a progesterone alone drug in the United States. We try to follow all these guidelines, but remember, USA does not allow use of Dinogest alone as a product for management of endometriosis associated pain. All right. So first important point, nowhere in the manuscript, nowhere in the literature, nowhere in any of the research papers, nowhere in any of the studies has it been found that it is going to be effective in making sure that your endometriosis disappears. They have never mentioned that. It is we who have mentioned that to our patients, just because we probably don't want to operate or don't know how to operate, right? So the product completely and categorically states that it is only to reduce the pain. The second thing which it states very beautifully, and now you will be able to correlate it with our first masterclass, is that it is effective only in approximately 70% of people who are having endometriosis. The reason for this is pretty simple. We spoke in our first masterclass that there are some progesterone receptors in endometriosis predominantly where there is progesterone resistance. So if there is progesterone resistance, the number of progesterone receptors are very less. And when the number of progesterone receptors are very less, how will a progesterone go and act? But the mechanism is slightly different. It is a progesterone, and once it enters inside the body, almost everything gets bioavailable within the next 2 to 4 hours. And what it does is it goes and binds to all progesterone receptors which it sees on its path. So it will bind to progesterone receptors in the breast, it will bind to progesterone receptors in the endometrium, in the endometriosis, in the uterus, wherever it finds a progesterone receptor, it will go and bind. Now, because it is going and doing a competitive binding, it is going to stimulate the entire steroidal cascade of progesterone, which will have a negative feedback loop on the brain, just like how we are giving meprate, regestrone, dufastone. Everybody is doing the same thing. Same thing Dinogest will go and do. It will have a negative feedback loop on the brain, and it will in turn reduce the production of FSH and LH, which will reduce the production of estrogen. And as a result of this, through an indirect mechanism, It is going to go and reduce estrogen, thereby reducing PGE2, which we spoke in the first class, and thereby reducing the pain. But in 30% of the women, what has typically happened, as you correlate in our third masterclass, that some of these women due to microhemorrhages have already formed fibrosis, and once fibrosis has been formed, there is no progesterone receptor. So no matter what Dinogest you give or how much Dinogest you give, or even if you inject Dinogest inside that entire nodule, Dinogest is not going to work, and that is the 30% women in whom Dinogest has not worked, right? Second, how long can you give Dinogest? So the manufacturer has categorically stated that it can be maximum given for approximately 16 months. Okay, because that is the maximum amount of study which they have. Of course, some studies have come out and stated that yes, it is safe to be used for 24 months. Somebody has said that yes, it is safe to be used for 30 months, but it can be safe to be used for 30 months because it predominantly takes care of endometriosis associated pain. And one important thing the manufacturer states is that if the patient is trying for fertility, then this is not the drug of choice. Because when a patient is trying for fertility, yes, there may be some amount of pain reduction, some amount of volume reduction, but it has got no benefit on fertility. As a result of which, if fertility is the situation, either you require a surgery, wherein majority of the patients will have a massive benefit if the surgery is done correctly, or you may opt for assisted reproduction. Now, in a country like India, where assisted reproduction is available at two places in every gully or every corner, what typically happens is people who are practicing isolated assisted reproduction, they don't even have a full-fledged OT. So the question of operating a patient does not arise, and they may switch the patient on these types of drugs. Okay. Then comes the question, is there any size criteria to give Dinogest? The answer is no. Just like elagolics, you can give Dinogest to everybody whom you want. You can give Dinogest right from brain endometriosis to inguinal endometriosis to perineal endometriosis to whatever, right? Then comes an important question. If you can give it to everyone, what are the side effects which are comparable? Remember, this guy, Dinogest, has got no effect on bone metabolism because it is progesterone, and progesterone has no effect on bone metabolism. As a result of which, it scores over GnRH agonist depot and elagolics, both of them, and it scores very, very heavily. And as a result of which, both of them are considered to be second line drugs, whereas Dinogest is considered to be the first line mechanism. That is, it is considered to be the first progestin first line drug which you can use for endometriosis associated pain. Right now, cost effectiveness, so definitely it is much more cost effective as compared to elagolics, very much more cost effective as compared to any form of GnRH agonist. So there is no question in that. Can a patient who is experiencing very, very severe pain be given Dinogest, and can a surgery be avoided? So let's give an objective answer to that. The manufacturer has never stated this. The deep endometriotic lesions do not get cured, so there is no cure to the lesions. You may have a temporary reduction in the pain associated with the lesions. So what typically happens is, for people who love this drug, they should try and understand that when you give it for a bowel nodule, when you give it for a ureteric nodule, when you give it for multi-compartment endometriosis, when you give it for adenomyosis, you have kept the patient happy as far as pain is concerned. The disease may progress inside, and you may end up with disastrous consequences. So on an average, we will do around 7 to 12 nephrectomies every year. 90% of these patients are on Dinogest. Nothing has happened to them otherwise apart from losing one kidney. We operate approximately 20 patients who are having bowel endometriosis, especially sigmoid endometriosis, every month. And out of this, approximately 3 to 4 patients will be having stenotic nodules. Nothing much would have happened apart from stenosis, because Dinogest was given to them for approximately 6 years. Is there any guideline to give Dinogest for 6 years? The answer is no. Is there any court of law which is going to save you if you give Dinogest for 6 years, or for that matter, 65 years also? The answer is no. Okay. So if in case you really want to do a smart practice, then remember, you can use Dinogest by giving the patient an option as a temporary management for pain. This temporary management can definitely exceed for approximately 12 months because the manufacturer stated 16 months. And you can try to give Dinogest in women who are adolescents, because in adolescent girls, pre-surgery it is very difficult to convince the family. As I told you, there are so many religious, there are so many social barriers which we have in our country, as a result of which people think that if a young girl is going to get operated who is unmarried, it may spoil her prospects of marriage, right? And as a result of which people will opt for ayurvedic medications, homeopathic medications for endometriosis, and definitely Dinogest is better than all of them. So this is what we have to keep in mind, especially when we are giving Dinogest. Now, two, three more things. Do we, how effective is Dinogest when we are trying to deal with extra pelvic endometriosis? So I've had 4 patients so far in this year whom we have operated for catamenial pneumothorax. Beautiful it is. They are on Dinogest and they end up developing pneumothorax, hemothorax very, very frequently. Nothing much happens. Sometimes the lung can burst from inside and it can cause some sorts of problems, but then that's fine. As long as you know you are not opting for a surgical method and giving Dinogest. We have 2 lungs, so even if one lung gets completely damaged, does not really matter, right? The same thing can be extrapolated to perineal endometriosis. The same thing can be extrapolated to abdominal wall endometriosis. If we realize something about extrapelvic endometriosis, the class which I'm going to take on extrapelvic endometriosis is going to be very, very interesting. And in that class, I'm going to be specifically telling you which extrapelvic endometriosis Dinogest will simply not work upon. Okay, so be ready for that class. You will all really like it. And before I conclude, I just want to tell sort of one important thing as far as rationalizing the use of Dinogest and consent taking for Dinogest is concerned. See, most of us may change the brand of Dinogest. Like, for example, if I have given a particular brand of Dinogest, Shilpa madam does not really appreciate me much. So she will say, "I he's given Visa and I will give you Dinogest, something different. And does it really help the patient? The answer is it does not really help the patient. Okay, the patient may think that you have given something. One more thing, remember, we are living in a world where chat gpt, AI, perplexity, everything is taking over very, very fast. Okay, the minute you put Dinogest and the minute you make a false promise, perplexity and chat gpt don't really make any promises. They give you the crystal clear information on Dinogest, and they also tell patients as to what they should be careful about. And you will start to notice that so many women on Dinogest end up having mood swings. So many of them end up having depression because that is very common. So many of them have breast tenderness and so many of them have sagginess of the breast. These are some of the complications which you should be explaining your patient, especially if they are on Dinogest. And the commonest complication which you are going to see, for which the patient is going to come to you, is going to be mainly for a patient who is having irregular bleeding on Dinogest. Okay, the bleeding has not been under control. There is continuous spotting, and women are extremely unhappy as far as taking Dinogest is concerned. Finally, before I conclude, is there any role of Dinogest in post-surgical management? Remember, any medical management is like chemotherapy. Okay, chemotherapy can only be given when you have R0 clearance of the disease. That means your disease has been completely cleared off. If your disease clearance is incomplete, if you leave a bowel nodule behind, I had a beautiful discussion with one of the vaginal surgeons who operates endometriosis vaginally. Now I don't know how he can enter the how the pouch of Douglas opens only. But yeah, I mean, probably if they are an expert endometriosis surgeon, still the pouch of Douglas may open. And you know what he says? I clear what I can see vaginally and then I give DMPA to the patient. Right? Better than doing a surgery is to then just give DMPA to the patient. The role of any medical management is existent only if you have achieved complete disease clearance and you are reserving medical management for post surgical suppression for microscopic disease. You cannot be using post surgical suppression for a macroscopic disease. Okay, that is not acceptable. So don't waste your Dinogest on those types of things. It's a very precious drug, isn't it? And simultaneously, there is one thing where you will all agree where Dinogest is simply not going to work, because people love to give Dinogest and nothing happens. Okay. And that is especially in something called as low rectal endometriosis or vaginal endometriosis. Remember, low rectal endometriosis and vaginal endometriosis has absolutely no space. So even minimal amount of fibrosis in that plane can cause severe amount of pain. And even if you give Dinogest to the patient, the shrinkage in the lesion is going to be less than 2%. So that pain is going to continue. And because that pain continues to the patient, they usually change the doctor. It is not, I was hearing in one of the conferences, and with this I will conclude. Somebody had told, very beautiful sari, not like Shilpa Madam saris, but ordinary average Indian saris, okay? And they went on the stage and they said that, I have given Dinogest to more than 5,000 people, and not a single person has come back to me. It is that good. Actually, it is not like that. A single person did not go back to them, because 4,900 out of them got operated from me. All right. And that is the reason they did not go back to the same consultant. So, if you think that the patient did not come back to you because you gave Dinogest, in almost all its probability, the patient has used its head and has gone to somebody who is operating. So, don't be very proud of making such statements, especially in a country like India in today's time, where it is very easy for an AI mechanism to counterfeit you if you are bluffing. Okay. So, with this, I conclude. I'll be happy to answer maybe two or three questions from everyone, and then we can call it a day.
Okay. So you told when it should not be used. So the only question that I have is, in your practice, I mean, if you ever have to use a Dynogest, I mean,
I would,
in what
I will
situation?
prefer, I will prefer oral contraceptive pills, ma'am, instead of
Okay.
Dinogest.
Okay.
Yeah.
And what about like I know you use mostly yeah, I know your the brand that you use. But in that, do you use a combination which has Dynogest in it, like a free
Can use.
days?
Yeah, it's completely fine to. I would prefer an oral contraceptive pill combination, because I want to use ethinyl estradiol, because 100% it has been proven that ethinyl estradiol is something which also ensures a negative feedback on estradiol beta receptors. So whenever I am giving a post surgical suppression, I want a suppression to act on estrogen receptors as well as progesterone receptors.
Yeah. And in situation, especially these adolescent girls
Yeah.
who with endometriosis and they are in terrible pain. So, do you think, I mean, I mean, till they kind of accept, until they let in the diagnosis sink in that they have endometriosis and they have to get operated. So, if at all, if you have to give, like, how long would you give in such young girls? Because it is quite safe compared to the
Yes, ma'am.
gynecology.
It is absolutely safe, can be safely given for approximately 16 to 18 months. There is no problem for up to 16 to 18 months as far as pain management is concerned, even by the manufacturer reports. Okay.
Yeah. So in cases where there are usage of Dinogest in fertility patients, like who think that like how it started propagation, where they say that fertility was not impacted, ovulation was not impacted with Dinogest, unlike inosipil and all that. That was what was told when it was launched. So if at all if they are trying for pregnancy, do you think the AMH is going to remain the same if they are on Dinogest continuously for
See,
say
remember
an
one
hour?
thing. If you have a chronic endometriotic cyst, the chronic endometriotic cyst fluid, the chocolate colored fluid, actually contains a lot of toxicity. So, what
Yeah.
it does is it is going to cause microvascular damage to the ovarian cortex. We are going to discuss that when we discuss chocolate cyst. It causes
Mm,
microvascular damage to the ovarian cortex, which ends up affecting the quality of the oocytes. Understanding?
mm,
As a
mm,
result of which, so many papers have come and said that, okay, bhai, if you have a good surgeon, go and operate, because you want a good quality oocyte also to become pregnant. And it has been categorically proven, okay, that untreated endometriosis gives rise to poor quality oocytes, poor quality embryos, and poor implantation, isn't it? So why
mm,
would anybody with even 10% logical mind take a risk in that? No, madam.
mm, mm. So we see a range of patients with endometriosis. Some have deep endometriosis with a bowel nodule, but they're totally asymptomatic. Whereas on the other side, you have like 3 centimeter endometriotic cyst on scan, and you see that they are in terrible pain.
Yeah,
So in such situations, okay. So if at all, if you have to give Dynogest,
yeah,
okay. So the first one, like I mean, the fertility is the only issue, but not the pain. The
yeah.
second one is pain is the only issue, but not about anything else, like not much findings also. So where in which situations do you think Dynogest is best given?
See, madam, guidelines are very clear. If there is pain and fertility is not the issue, then the patient should not be given medical management. Patient should be operated.
Mm.
If the fertility is an issue and
Mm.
pain is also existent, then you
Mm.
are supposed to weigh between, what is better for the patient.
Yeah.
If there is no pain and only fertility is the issue,
Mm.
and if there is grade 4 endometriosis
Mm.
without a nodule, then you
Mm.
should do fertility first. If there is grade 4 endometriosis with a nodule somewhere, bowel nodule, ureteric nodule, bladder nodule, whatever, then you
Mm.
should remove the nodule and then proceed with the line of management as far as fertility guidelines are concerned. These are not my guidelines. These are guidelines across the world. These are Shree guidelines published everywhere, okay, and endorsed by many, many societies. What typically happens is we live in a country where we have guidelines of convenience, okay.
Mm.
I feel that this is good. That is why I am doing it. Right? That may or may not be very good. Innocent patient may or may not understand your intention behind it. And if the patient does not understand, ultimately the patient will go to a specialist and will not fall prey to false opinions. So we have to incorporate that in our practice, I think.
Mm. So you spoke about so much about these guidelines and all that. So if at all, if the patient has fertility issues, okay, and as you say that many a times you do the pickup and then wait and then you do the surgery and then you think of doing a transfer. So
That is only when the ovarian cyst, endometriotic cyst is less than 3 centimeters in size.
yeah, yeah, yeah. So in such situations, like you still wait post surgery with Dinogest, like post this thing for a couple of months before you do the transfer.
Yeah, yeah. We wait for 6 weeks, but we don't give Dinogest, no, ma'am. We give oral contraceptive pills. You've seen that. We give Dronis 30.
Yeah, yeah, yeah. So okay, I think if we talk, I mean, there is so much more. Aarti, if you have any questions, please go ahead.
Yeah, so Jay, thanks for challenging the conventional wisdom regarding Dinogest, and you have brought to light the good, bad, and ugly of Dinogest. So you mentioned that the good part, only good part is temporary pain relief, cost effective in maybe the adolescent group of patients. The bad part
Correct.
you mentioned was it's not going to act in multi-compartment endometriosis and endometriosis extrapelvic and vaginal endometriosis, low rectal endometriosis. The ugly part is you said that, it's just being used for years together and patients are ending up losing a kidney or having a bowel stricture. So you beautifully mentioned the good, bad, and ugly. So my question is, you mentioned that if the endometriosis surgery is complete and it acts like chemotherapy and you can give it post surgery
Definitely.
ear microscopic disease. So
Definitely.
I saw a patient the other day who had 5 previous laparoscopic surgeries before they came to us for endometriosis. And now this patient has again come back with pain and she's traumatized by the thought of surgery.
Yeah.
So one question is, can we consider this as an option?
Madam, if she is traumatized with the thought of surgery, then I would give a combination of letrozole plus registron or letrozole plus Mirena, because I want anti-estrogen to be inside that body rather than just a progestin. Okay, I want anti-estrogen inside. Now, of course, ma'am, somebody who has been operated 5 times is not going to be very happy to be operated the sixth time. But usually, what is going to happen is the pain quotient is so severe that after 1 to 2 months, usually they will come back and get operated.
But the regestrone and letrozole combination, we don't give for more than 90 days, Jay.
Yeah, not more than 90 days.
Right. So again, it's only temporary. So basically, you're giving the medication till they come to terms with the fact that they require surgery.
Correct. Correct. Correct.
Now, what if you give Dinogest and they have pain relief? My next question is, you said that the patients are put on Dinogest for years together because they are experiencing some pain relief, but then they end up losing a kidney or having a sigmoid stricture. So can such patients, such specific category of patients
Can
be
be
put
given,
on
madam.
Dinogest and followed up?
Also, ma'am, these type of patients can, instead of giving Dinogest and taking a daily tablet, you can also put Mirena inside and see. Because in this type of situations, if you put Mirena, you are going to offer pain relief to the patient. Okay. But what is important is, see, people are people will only take home this point. Are Jay had told you put Mirena inside, no matter what happens, nothing is there. But the thing is, you put Mirena inside when you don't see a nodule or ultrasound or MRI. Correct.
Right.
That is very important. If you have seen a 2.8 centimeter nodule somewhere on the sigmoid or on the bowel and you say, no, we'll put Mirena. See, that is nonsense. Understanding? I recently operated somebody who had catamenial pneumothorax and they had put Mirena. Where is the lung and where is the uterus? they, they, they are
It's
separated by a
okay.
diaphragm, okay? So,
It's okay.
what
I
typical.
just had a case of that same thing. Okay, I might do the same thing.
Right.
I'm
So,
joking.
So what had typically happened is even the patient was wondering that sir lung ऊपर है and uterus नीचे है तो वो कैसे काम करेगा, you know. And see, somebody convinced them for a Mirena was put. Of course nothing happened, so that's apart from that, you know, she developed hemothorax 4-5 times. So what typically happened is on her fourth hemothorax she was pretty confident that 100% this will require surgery, and ultimately she got operated. Okay, so see, God is very kind also, ma'am, to such people. One person will give some nonsense, but the disease is such that the disease will keep on expressing itself in various mechanisms, and ultimately patients will come to terms with it. If your patient is better with Dinogest without the presence of a nodule, good na, she probably avoided a surgery which she any which ways wanted to avoid. But if there is a nodule and you have not documented it, then of course it is the mistake of us as practitioners for not having the expertise to report it.
Right. And if a patient is in the perimenopausal age group, can we consider this as an option for at
If
least
there is a
at
nodule,
40s? If there is
yeah,
a
yeah.
nodule, again it
If
won't.
there is a nodule, then there is no question of considering. We operated now, ma'am. We operated 62-year-old lady with mast bowel endometriosis, right? So I don't think. See, uh, even if ovaries have stopped functioning, even if their neighbor's ovary have stopped functioning, all these things have got no correlation to that nodule inside, madam. Because what we are trying to correlate everything is to a hormonal theory.
Right.
Correct. Endometriosis has immunological theory, endometriosis is implantation theory, stem cell theory. God knows which theory is working in which patient, ma'am.
Right, right. So basically, and this drug can be used only as a temporary pain relief interim treatment in patients where there is no evidence of fibrosis or nodules.
According to the manufacturer. Okay. The
Yes.
manufacturer is very clear on where you can use it. As I told you, we have made guidelines of our convenience, not the manufacturers.
Okay. Thanks, Jay. I think I'm done, Shilpa.
Thank you so much, everyone. We have almost like 100 people at 11 o'clock listening to not use Dinogest. I'm very grateful for that. So thank you, sir. Thank you. It was very enlightening to hear from you for the first time that how not to use medical management unnecessarily and counsel the patient correctly for surgical management whenever it